cannot spell Hodgkin's. So we've done Hodgkin's, so now we're doing these ones. And there are a lot of them. Of lymphomas, which are not Hodgkin's lymphoma by definition, as in, you know, this has a red Steinbeck cell. So the non-Hodgkin's, again, they present with painless lymphadenopathy. The presentation of lymphomas and of Hodgkin's and non-Hodgkin's is similar in the sense that there is that presentation of painless lymphadenopathy, and there could be B symptoms. And the staging again is exactly the same. We use the N-ABA. The treatment approach is similar in the sense that it's chemo, but most of the non-Hodgkin's will have the watch and wait approach because they are indolent, slow growing. There is really no need to start treatment early, because treatment then becomes toxic or is ineffective, or the quality of life or the disease pathway does not change. So really there is no need to subject someone to chemotherapy, which has unpleasant side effects, when really the quality of life, the course of disease, the prognosis will not change based on the treatment approach. So with non-Hodgkin's lymphomas, really the management plans are usually based on the treating team, the patient, the type of the cancer as well, and you know, and based on the staging as well. So those are the approaches that I use. So the first one that I'll just ever so briefly discuss is follicular lymphoma. And follicular lymphoma, obviously it is a non-Hodgkin, is based on is a B-cell lymphoma with a transformation of T14, 18. Oh, is it 814? Gosh, now I feel stupid. No, it's 1418. Am I correct? I think I'm correct. I am correct. I've just been going through all of them. There are so many non-Hodgkin's lymphomas, so many transformations. For example, Burkitt has 814, 28, 822, and one of them has 34. There's so many transformations. I don't want to get bottled down. Anyway, the transformation means that a gene that belongs in one chromosome moves over to another chromosome. In this cell, the gene BCL2, which normally belongs, no, it's actually, is it? It is BCL. Yeah. BCL2, which normally belongs on chromosome 18, moves over gene. I know gene must be done in smaller, but it doesn't matter. This is the protein. Moves over, is translocated from chromosome 18 to 14. And when it gets there, it then is then inserted closer to IG heavy chain, and that movement, its movement then encodes for an anti-apoptosis apoptosis. And really, all that it means is that in order for a cell to die, like normally, right, in the cell we'll have cytochrome C, right? So cytochrome C sits there in the cell, and when it's time to die, Bax is inserted as a channel. So this is called Bax, is inserted as a channel, and that channel then allows cytochrome C to enter the cell cytoplasm. I should have used a different color. So Bax then allows cytochrome C to enter the cell cytoplasm, and when cytochrome C, I'm actually going to do cytochrome C as a green. So as cytochrome C enters the cell, it comes in, finds caspase 9. So this is the cell cytoplasm. And then so this would be cytochrome C, C. So then it activates caspase 9. So now we have active Cas9, and active caspase 9 then causes organelle dissolution. Oh gosh, dissolution. So which means all the ribosomes, all the organelles of the cell really will just be disrupted and dissolved and disorganized, disaggregated, and then the cell will undergo apoptosis. It's as simple as that. So really, cytochrome C comes in there, activates caspase 9. Caspase 9 causes organelle dissolution. This gene comes in and blocks this exit of cytochrome C. So it closes that channel there, and when it's there, it means that the cell has no cytochrome C. Oh, I should have used red. It means that the cell has no cytochrome C, and when the cell doesn't have cytochrome C, you have no active caspase 9, and when you don't have active caspase 9, you have no organelle dissolution, and when you don't have organelle dissolution, you do not have apoptosis. So basically, it stops apoptosis, and therefore cells become immortal. So it confers immortality to the cells. And again, it will form a mass, because sometimes I feel as though when I'm talking about lymphoma, well, as I've been doing lymphomas, it feels as though I've already covered it, because they are all so similar in the sense that presentation is similar. But anyway, this is the transformation that occurs, and then once it's diagnosed, based on all the diagnoses are based on lymph node excisional lymph node biopsy, imaging with chest X-ray, and with a CT scan of the chest, the abdomen, and the pelvis in order to stage it correctly. They are all staged based on the Ann Arbor staging system. And with follicular lymphoma, once it has been staged, there is also the flip. Then after staging, like you stage using the Ann Arbor, and then perform a flip index, which is really the follicular lymphoma international prognostic index. And this flip is based on, if someone is aged over 60, it's based on giving one score for each of these. If someone is based over 60, they get a score. If someone has raised LDH, which obviously is a marker for tumor burden. So they get a score. If they have anemia or reduced hemoglobin, anemia, they get a score. And if they have more than 4 lymph node involvement, they get a score. And there's something else which I've forgotten. And if they have a stage, if they have more than 2, like, or is it 3 to 4, they get another score. So at the end of this all, we then have people who score 0 to 1 are called low risk. Then people who score 2 to 3 are called intermediate or medium risk. And then anyone who scores over 3 is high risk. And this then governs the starting treatment. So then you take this together with the N upper score, which obviously features there, and then it's used to guide management. And the management for follicular lymphoma is CHOP. And usually, say if someone, if usually they will use, this is rituximab, this is cyclophosphamide, this is, I've forgotten the name. This is prednisolone, this is of, vincristin anyway. I've forgotten the name of that. Anyway, these are chemotherapies. So usually they will use the rituximab as to induce remission, and then blast it with the chemotherapy. But again, the treatment can be watch and wait, or give rituximab to try to induce remission. And obviously, if then it's still progressive and they are not doing as well, then you can give the CHOP aspect of the CHOP. So this is CHOP chemo. And that is the mainstay treatment of follicular lymphoma. Follicular lymphoma can, however, is known to its complication. It can transform into a diffuse large B-cell lymphoma. So, which is a much more aggressive cancer in comparison to a follicular lymphoma. And follicular lymphoma, I forgot, did I mention that the cells, I know I probably went too far in talking about the flip and the treatment, but really the way the morphology is usually centrocytes. Again, it's B cells, so it's usually centrocytes, which have small and cleaved cells. This is the morphology, really. What you see under the microscope. They can also be centroblasts, which are obviously larger than than the centrocytes. So when it transforms, you stop seeing centrocytes and then it becomes diffuse large B cell. And obviously all B cells, B cell markers, will have CD19, CD20, CD22, However, follicular is CD5 negative, I think, and which is what differentiates it from mantle cell lymphoma. So that is, follicular lymphoma at a glance. The important thing is that transformation. The important thing is its treatment induced with rituximab, but obviously the introduction of rituximab has to be specific and individualized to the patient based on the N upper stage and flip, because there are studies that say, treating doesn't really change the quality of life, and it doesn't really change the prognosis. So really, all these things have to be balanced by what is best for that patient, and the treating doctor as well, who know the patient, what do they feel is best to do. So really, that is follicular lymphoma. It's usually centrocytes and semiblast, the morphology, and the genotype is the BCL2, which is an anti-apoptotic based on the transformation of 14 and chromosomes 14 and 18. And then the next one, I'll very quickly just say the diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma. Again, it has so many subtypes, and there are so many types of it, and who recognizes. So again, it is a lymphoma of B-cell origin. The cells are large. The morphology of the cells are large. Who recognizes anaplastic, obviously anaplastic is not even the most centroplastic, these are the most commonest, the three most commonest: immunoplastic, then there is the anaplastic, then there are other types as well, and subtypes. So the important thing really about the diffuse large B-cell lymphomas is that sometimes it is called unclassifiable. It can be called unclassifiable, particularly if the diffuse large B-cell lymphoma has features that also overlap with other cancer, that overlap with other cancers. So we can call it, an unclassifiable. We can call it, say, if it's centroplastic unclassifiable diffuse large B-cell lymphoma with intermediate features of diffuse large B-cell lymphoma, and perhaps Burkitt or a Hodgkin's or any other condition, and these are actually called double hits, because it ends up being two cancers in one, and obviously its actual pathogenesis, its etiology, is again based on EBV, but it can arise from other cancers. and its treatment again is R-CHOP. I'm not going to spend R-CHOP. And it can be treated with radiotherapy. And immunotherapies. And the radiotherapy will have to be specific for where the mass is, and focused on that mass. So that is all. I probably will come back to it another time. But really, so that once you have, you know, it's staging again is based on Ann Arbor, and it will be graded as well using the International Prognostic Index. Again, it will measure all the features similar to the lymphoma, including LDH, which again then it's graded between low risk, low intermediate, and then high intermediate, and then high risk. And again, that's how, and then that guides treatment similar to follicular. And then finally, yes, the acute lymphoma. I'm sure I'll have to come back to these ones at another stage. It's just that you know, the reason why I've chosen to cover diffuse and follicular is because they are much more common. They are the commonest non-Hodgkin's lymphomas, and they both affect older people. And while follicular lymphoma, sorry, it's non-Hodgkin. Follicular lymphoma is the commonest in adults. Diffuse large B-cell is the commonest in men who are over 60. So they are the two commonest, which is why it's always important, you know, common things being common, to cover them. So then Burkitt's. Again, a non-Hodgkin's lymphoma that mainly affects children between the ages of 5 to 7 years old. Much more common in males. Lymphomas seem to be much more common in males. Again, it is a blood cancer. It is a non-Hodgkin's. It seems to be. It's not as common, but the focus is because it affects children. So that's why it's important to include, you know, after talking about things that mainly affects old people, to talk about something that affects younger people. And its genotype will be the transformation 8, 14, 8, 22, and 2, 8, and they all result in CMYC gene upregulation, and it leads to increased proliferation. And it presents usually, in fact, before we even talk about the presentation, there are three classes, there are 3 types, or 3 variants, in fact. There is the endemic, which is also called the African variant. And it's usually found in areas where there is high malaria. I think it's the Plasmodium falciparum. Oh God, I should know how to spell this. Having gone to the London School of Hygiene and Organism. Anyway, it's the Plasmodium falciparum. And apparently, because when it's wherever it's endemic, it reduces resistance. So I'm checking to see it's recording. It reduces resistance to EBV. So when people become infected with EBV, they can't seem to fight it off due to their resistance to that virus being reduced by the endemic nature of malaria. And on this aspect, I did wonder if this is me thinking, not what has been confirmed or what I've read anywhere. I did wonder if this perhaps it's because malaria is, if it's endemic in that place, then it reduces the herd immunity really of instead of being host dependent, as in if the entire village, or because since it's like if the entire village, or if the entire settlement or whatever has a reduced herd immunity to EBV due to that increased malaria. So I wondered if related if it was a single host or if it's herd immunity. So I don't know, I will find that out. But anyway, so that then the high incidence of malaria reduces resistance to EBV, resulting in endemic Beckett's, and it usually has presents with a maxillary mass that also affects the orbit. The mandible is hardly ever affected, so it also will then, if it affects the central, it can affect the central nervous system and the meninges, and the spinal cord, and it can also affect cranial nerve 3, which is the oculomotor, and cranial nerve 7, which is facial, which obviously makes sense based on affective orbit and it being in the face, taking on the maxillary, which is obviously the upper jaw. So then another variant is the sporadic, which is found in non-malaria, and is not linked to EBV, might present with abdominal mass, mass instead of facial. The facial is not as common on this one, and so it's not really linked to EBV, and it might have an abdominal mass. And then the other one is the immunodeficiency. And the immunodeficiency really could be HIV linked, it could be transplant linked, or anyone really on immunosuppressants for whatever condition there is. So these are the 3 types. So in order to diagnose you know, a biopsy will be performed. Imaging similarly to other non-Hodgkins will be performed, but you must also do an HIV screen, serology, and a Hep screen as well, just to have that as as a basis for, because really obviously this one can have that as well. So really it's important to that, and obviously these as well will guide treatment. This back hit is quite aggressive, highly aggressive. So there is no watch and wait, you do not wait, you very much give, once the diagnosis has been confirmed, obviously with biopsy, with bloods, with imaging, and staged as well, treatment must commence. And treatment is chemo, in fact not even chemo, because it's highly aggressive, highly proliferative. Treatment, high dose chemotherapy, and obviously this was given in cycles. This is not at all like the other ones where you give rituximab and then wait a little bit to see how things progress. This is a highly aggressive cancer, and high dose cycles of chemotherapy have to be given. It can either be cyclophosphamide, vincristine, there are combination high dose chemotherapy cycles and combinations as well. Other treatments can also include immune based, bone marrow transplant, stem cell transplant, surgery, targeted radiotherapy, but the most important thing to remember is that this is the mainstay treatment really. All the other ones are not the mainstay treatment. Obviously these ones can be given in saying if it becomes refractory or if there is a relapse, then obviously these ones can be given, and surgery can then be performed once the tumor burden has been reduced using chemotherapy. Radiotherapy can be undertaken as part of chemotherapy, but radiotherapy cannot be used as monotherapy because this is a highly aggressive tumor that will not respond to radiotherapy. Radiotherapy is far too slow to do anything really, to actually kill the cancer. Radiotherapy can also only be effective if it's given with a chemotherapy, high dose chemotherapy, and then radiotherapy, perhaps if it's a jaw mass, to then target it there, or if it's an abdominal mass, to then target it with radiotherapy. But it's not, I need to clarify, not monotherapy and not mainstay. There is only one mainstay, high dose chemotherapy. So the transplants can be given as well, as part of that treatment plan. Obviously because